Thank you. So thank you so much, Dr. Sanya, for that kind introduction. And I would like to thank AstraZeneca for this opportunity. So this is one topic which I think all of us in this audience know, and I'm sure we are going to have a lot of interesting opinions on the panel discussion as well. So we all know now that we cannot get away without doing molecular studies for lung cancer, and in all the Globocan data, lung cancer is right there on top. Though the Indian data shows that the oral cavity cancer has come up by a large way in the recent Globocan compared to the 2000 Globocan. So overall, it's a very high, it causes very high mortality in both males and females. And males to female ratio is slightly skewed because of higher incidence of smoking among males in Indian population, and also incidence of non-small cell lung cancer is much more when compared to the small cell lung cancer. So as we can see, it's very important now to know what is the histology of malignancy we are dealing with, whether it is squamous or adenocarcinoma. So basically, in all the guidelines, it is non-small cell lung cancer. So they're all taken in a basket. But when we are seeing adenocarcinoma, we automatically check for all mutations. Conventionally, we have been always testing for EGFR, ALK, and ROS. And now, even in squamous histology, we are asking more and more EGFR mutation, as we have discussed multiple times in a lot of webinars, that we are seeing a lot of EGFR mutation in the squamous cell carcinoma histology as well. So, in addition to EGFR in the squamous cell histology, we are also, there's a lot of data coming where they are finding PIK3 kinase mutation. So that can be targeted with the mTOR inhibitor. Also, more and more EGFR inhibitors. Also, there are data in other malignancies. So maybe in future we will be testing for a lot more molecules which we did not have thought of testing in 2021-22. So the evolution of lung cancer has happened from the diagnostic point of view, where it was just enough to know whether it's adenocarcinoma or squamous cell carcinoma, because we would decide what chemotherapy to give. So for adeno, we would give pemetrexed-based platinum doublet, and for squamous was gem carbo or gem platinum plus or paclitaxel platinum. So now we have refined that. So whenever we are seeing adeno or squamous, we are not happy. We need much more. So basic minimum, we are asking for EGFR, ALK, ROS, and now in the last few years, additional markers have come in like MET, RAS, KRAS, BRAF, HER2, RET. So these are the newer markers which we are supposed to do for every patient with probably adenocarcinoma on the histology. So by and large, EGFR forms a chunk of the mutation, and as you can see here, we used to send it to some of the labs where they would test for T790M mutation upfront as well. So initially we used to be quite confused as to why we are testing it, where our understanding was someone on EGFR inhibitor develops a T790M mutation as a resistant, part of resistance. So, but now we are seeing some patients have T790M mutation upfront as well. So it makes sense to test for that when we are testing for EGFR mutation. So EGFR, ALK, ROS, these are the basic markers which we do, and in my practice I do it. I have right now confined only these three markers, because most of the patients can get it done at minimal or nominal cost. And of course, in someone who can afford, we are also getting the PDL1 expression done. So and getting the tumor proportion score or combined proportion score, and based on the percentage of expression, we decide whether to give monotherapy with IO or a combination with chemotherapy, depending on what is the lab report. And as per this flow chart, we decide whether to give IO only or IO with combination. By and large, these are the four markers I think we are all doing. The fifth marker, T790M, comes as a default in some labs, but most of the labs do have EGFR, ALK, ROS as standard and PDL1 as add-on. So what is the methodology by which we are supposed to test for these mutations? So EGFR, actually, it is supposed to be a PCR based, ALK and ROS by FISH, and PDL1 by IHC method. So from empirical therapy, where we had just which chemotherapy to offer the patient, now we are going slowly towards molecular diagnosis, and also most of our decisions are based on these molecular studies. So also now NGS is being performed in most of the labs, and if patients can afford, I think most of us are opting for NGS because we want to test for all the possible mutations upfront. And it is a confusing scenario when you get 2 or 3 mutations in the same patient. So basically, these are the exon mutations which we are looking at: exon 18, 19, 20, 21. So exon 19 deletion and exon 21 L858 are the most common activating mutations, are the most common of the EGFR sensitizing mutations. And also what sample to test. So FNAC is not enough. So wherever possible, for example, if a patient comes with a deep-seated primary lung lesion which cannot be biopsied, if patient has a pleural effusion which tests positive, I think cell blocks can be prepared, and we may get a higher yield of EGFR mutation. Recently, one patient I had sent in a similar way, and I got the EGFR positive in that patient. So, what are the factors determining the choice of EGFR mutation testing? So, the commonest factor would be the availability of tissue. If it's a deep-seated small primary, then it becomes challenging to do a biopsy because of risk of developing pneumothorax, and also bony lesions. We have discussed many times in our meeting here. To do a biopsy from a bony lesion, then to decalcify and get a EGFR mutation becomes that much more difficult in patients with bone only metastasis. So there is a lot of things which are dependent on the patient, and in such a scenario where doing a biopsy from a deep-seated lesion is difficult, we go for a circulating tumor DNA. I think that there is a subsequent slide. So basically, IHC or FISH is not recommended for EGFR. So PCR-based assay is what we should be doing. I think that is Scorpion-based and RT-PCR. So basically, the tumor content should be around 10% or more to get a proper report. So all this is one scenario where there are, many times we come across this scenario where accessing the tumor becomes difficult. In that particular challenging scenario, we make use of this liquid biopsy, and if we are able to get a tumor DNA on that, then we are able to run the EGFR mutation. I have got a report in 1 or 2 such patients as well. The second most common thing we test for after EGFR is the ALK gene. So initially, how it evolved was when we used to test only for EGFR. When ALK and ROS, we started testing for it was after testing for EGFR, and ALK and ROS was a reflex testing. So we would test them only once we got a EGFR negative report. So we used to wait for because they are mutually exclusive. So if you would have a EGFR mutation, we would not generally test for ALK or ROS, and only when we would get a EGFR negative, we would test for ALK or ROS mutation. So ALK is anaplastic lymphoma kinase. It's caused by rearrangement of EML4 and ALK gene. It's a fusion oncogene, and it is found predominantly in adenocarcinoma of the lung, and the prevalence is around 3 to 5% in Indian population. False positivity rate is actually 0.1% with FISH. So, but still we get ALK done by IHC method as it is a very sensitive method of testing for ALK. In terms of RT-PCR, there are a few challenges. Some alteration in the fusion, like there will be some variants which might be missed, and it requires multiplexing. So there's a lot of technical challenges when RT-PCR is performed with ALK. So for now, I think most of us are convinced that we do IHC for ALK as well. Likewise, for another target called ROS1, this is another important mutation which we come across in adenocarcinoma of lung. The incidence is around 3% in our Indian population, and we have a drug which targets ROS1 mutation, crizotinib. So even though FISH is relatively easier to perform, there's a high failure rate associated with the FISH. So there are a few ongoing clinical trials, phase 1, where they're trying testing it with anchored multiplex PCR and trying to tag it with NGS. And also there are, but still for now, ALK and ROS, we are still testing with IHC for our day-to-day clinical practice. So this is the algorithm which all of us are following. We are testing for EGFR, ALK, and ROS upfront. EGFR by RT-PCR or NGS, depending on the patient's affordability, and ALK and ROS by FISH. I think most of with IHC, most of us are doing that using the coupons from some of the companies, and that is that is very helpful for our patients. Also for PDL1, I think no talk is complete without discussing PDL1 expression. So I think everyone knows how PDL1 is targeted, and there are so many platforms available like SP263, the DACO22C3, and SP142. So there are certain conditions where we use each of these. For example, in triple negative breast cancer, we use the SP142 platform, and for the other solid tumors, we use the DACO platform. So depending on the type of tumor we are dealing with, we ask for a relevant PDL1 testing methodology. So to put things in perspective, by and large, we do EGFR ALK-ROS for almost every patient. The secondary panel would ideally have a BRAF, MET, RET, or HER2 with KRAS. This would be probably on an NGS. So, but for my clinical practice also, I am more or less confined to EGFR ALK-ROS and the odd patient PDL1. So this is the same algorithm put in the same way. So if someone has EGFR positive, we would ideally give TKI plus or minus chemotherapy depending on our center of practice. And for ALK positive, ALK inhibitor, either crizotinib, alectinib, and likewise for ROS1, we would give crizotinib. So it's very the TAT is the one thing which all of us are really worried about. We are as worried as the patient. So ideally, TAT should be around 1 week. Most of the IHC based, we are able to get around a week's time, depending on the working days, probably around 10 days. But PCR takes that much slightly longer time. And one more thing is slightly more expensive. So for most of our patients, we prefer IHC for ALK and ROS and PCR for EGFR. So most of the labs should strive to get a shorter TAT, and ideally these things should be performed in-house. We do have an in-house digital droplet PCR for EGFR. Still, it is not standardized. We are working on it. So that is for the liquid biopsy. So I think going forward, most of the hospitals will have in-house facilities for most of these tests. So now coming to from the bedside to bedside, osimertinib as adjuvant therapy. Now from with the ADAURA trial, we know that there is data where we should ideally test for EGFR mutation in early stage lung cancer as well. So this is the data from the ADAURA trial. We can see that there is a significant number of patients harboring EGFR mutation in the stage 1, 2, and 3 setup as well. So it's pertinent that we test for EGFR in the early stage lung cancer as well. This was not the teaching when we were in training. So so now I think we should test for EGFR ALK-ROS even in the upfront in the resected lung cancer as well. So there are so many ongoing trials. I'll not go into details of these. So and also there are a lot of phase 3 trials where they're trying IO in the adjuvant setting. These are the following trials with nivolumab, pembrolizumab, durvalumab, and atezolizumab, and they are looking at. The interesting thing is some of the trials don't even have chemotherapy doublet as the standard backbone. So they are randomizing after resection to IO. So it will be interesting to see what will be the outcome of the studies. But I'm not sure how many of our patients will be able to complete the whole course of 1 year with these drugs. So it will be interesting to know the data though. And there's also a lot of trials happening in the neoadjuvant space where they're trying to look for these mutations and trying to make the unresectable stage 3 adenocarcinomas, NSCLCs with EGFR mutation, trying to make it resectable. So that is very interesting. I think this is far more interesting trial which are happening, and the data which comes out will be very interesting to see. And not just the EGFR ALK-ROS, they're also looking for rarer mutation like NTRK fusion, BRAF, and RET fusion. So the Nautica 1 study hopefully will give some positive data in in time to come. So likewise, in the adjuvant setting, IO therapy also looks very promising, where they are trying to combine IO with chemotherapy and then continuing the maintenance with IO alone. This will also be little challenging in our country, but I think the response rates will be very good with IO with chemotherapy doublet, and there are a lot of interesting data awaited from these trials. So to conclude, biomarker testing in non-small cell lung cancer has evolved from single gene to multiplex testing, and more and more meetings will help us understand the study, understand the sample requirements, and also we should have target at least 10% of tumor content in the biopsy to prevent the delay in processing. And we now know that adjuvant osimertinib prolongs DFS in patients with EGFR positive non-small cell lung cancer. And yeah, a lot of interesting IO data coming up in this space. So with that, I think I come to an end of my presentation.